My thesis topic is Elan score, a probable indicator for mortality among cases of acute decompensated or acute Denovo heart failure admitted in tertiary care hospital. Coming to the introduction, significant hurdles are faced in the management of patients admitted with acute decompensated heart failure since they present with distinct types of cardiac disease, wide range of age groups, and comorbidities. Decongestion is the common measure of successful treatment. After all, decongestion is not the single factor deciding the prognosis. To reinforce the therapies or enhance follow-up of patients with ADHF or de novo heart failure at higher risk, a dependable risk stratification might be used prior to the discharge from the hospital. The 2017 ACC update of HF guidelines suggests that a pre-discharge natriuretic peptide level is useful to establish a post-discharge prognosis during a HF patient hospitalization, for which they have cited Elan HF, that is a European collaboration on acute decompensated heart failure score, which uses NT-proBNP levels at admission and pre-discharge along with clinical and laboratory parameters. The primary objective of my study is to predict the mortality in ADHF and de novo heart failure cases based on NIHF score during 6 months follow-up. And secondary objective is the cumulative of a cumulative mortality curve for cases as per all four NIHF score categories. It's a hospital-based observational study, and sample size was 130 cases collected after the in conclusion with the statistician, and the inclusion criteria is age more than 18 years, presenting with acute de novo or ADHF on basis of history, symptoms, and signs, and patients without decompensation have been excluded. And the order of the study was the patient admitted with ADHF or de novo heart failure satisfying the eligibility criteria were enrolled for the study, and basic investigation were done. NT-proBNP levels are measured at admission and discharge, and the NIHF score was calculated. And the variables including the NIHF score were absolute level of NT-proBNP at discharge, that is 1 point was given for 1500 to 5000 per gram, and 5000 to 15,000 3 points were given. More than 15,000 4 points were given, and 1 point each was given for the NT-proBNP reduction less than 30% at discharge, age more than 75 years, peripheral edema, SBP less than 115 with hyponatremia, blood urea, and NVH class 3 or 4 at the discharge. The risk group were categorized into low risk less than 2 points, intermediate if 3 to 4 points, and high if 5 to 7 points, and very high if it's more than 8 points. Follow-up visits were performed after discharge for 6 months, and event registration was done. And primary endpoint was complete all-cause mortality and readmission of for heart failure at 6 months. This is the flow chart. And the statistical analysis included continuous data summarized using mean and standard deviation. And the mean difference was analyzed by student t-test, and Kaplan-Meier curve has been analyzed, and significance was kept at 95%. Results: the mean age of patients in our study was 56.8 years plus or minus 11. More were males, 58%. NHA class 3 in 61%, class 4 in 39%. Peripheral edema was present in 67%, and AF was present in 38%. Anemia in 9.3% patients. And the NT-proBNP reduction was percentage was 51.3% in all the cases. And the NT-proBNP reduction of less than 30% at discharge was evident in 17.6%. And low risk score was in 23% patients, and the intermediate risk group included 21.3%, and high risk group included 31.2% patients, and a very high risk group included 20.4% patients. Total number of deaths in 180 days follow-up was 25%, that is 27 deaths. This is the basic baseline characteristics of the patients, and significant p-value was present among the NIHF score groups with when compared survival with the mortality group. And p-value is significant for the NT-proBNP reduction less than 30%, and also at the discharge level significant reduction. Less than 30% NT-proBNP reduction at discharge was more in patients who died, that is 48% versus survived. And at discharge, NT-proBNP levels are higher in the patients died who compared with the survived. The events and survival, the survival events were more in the high and very high risk group, that is 26% in high group and 59% in very high risk group. And the survival time was lower in the very high risk group, that is 130 days, and lower in the very high risk group and higher in the low risk group, that is 177 days. And the pairwise comparison of mortality risk was done, and with significant p-value when compared to very high risk group with low, intermediate, and high risk group. This is a Kaplan-Meier curve showing the cumulative mortality very higher in the very high risk group, followed by high risk and intermediate, then followed by low risk group. And the adverse event that admissions, that is readmissions and death were higher in the very high risk group, that is 90.9%, and high in 50% in the high risk group and 8% in the low risk group. Discussion. Patient in our study had the mean age of 58 years and peripheral was present in 67.6% compared to Salah et al. Study, and AF was present in 38% patients compared to Salah et al. Study. Anti-probability reduction less than 30% at discharge was evident in 70.6% compared to 38% in Salah et al. Study. Significant p-value. Patients with higher levels of anti-probability at discharge or an inadequate at decline during hospitalization had higher risk of readmission or death within 180 days, which was comparable to Vardiana et al. Study. And in our study, total number of deaths was 25% compared to Salah et al. Study, which was 15%. And study was comparable with the coach risk engine and optimized HF study, and the stepwise increase in all cause mortality for the 4 risk groups increased at the rate of 3.7% for the low risk group to 48% at the very high risk group, which was comparable to Salah et al. Cohort study, which was a validation study, which is 3.6% for low risk group and 51% for very high risk group. Strength of the study is its broad applicability and also its easy calculation. Limitations: the use of all-cause mortality instead of cardiovascular mortality as the primary outcome, and a multicentric study is required for validation of score in Indian population. Conclusion and the take-home message: what is already known about research is Elan HF score allows accurate prediction of 6-month mortality of patient hospitalized for AHF with the use of easily obtained clinical and laboratory variables in addition to absolute nitrate peptide levels at discharge and relative change in nitrate peptide less than 30% from the admission values in Western population. Patients with higher Elan HF score or risk score at discharge can be predicted to have higher event or mortality rates. What our study adds is Elan HF score is a reliable indicator that can be used for risk stratification and prediction of mortality for hospitalized patients for IDHF or Denovo heart failure, which is first time applied in Indian population. And patients with high and very high risk score may call for more aggressive treatment and also for a much closer follow-up, possibly in heart failure management. Thank you.